Okay, it's a few minutes past the hour at this point, so I'll go ahead and get started. I'm very pleased to invite you all to today's webinar, where we're going to speak a little bit about updates of transplant and sickle cell disease, and then excited to hear from two patient advocates about their journeys with sickle cell disease. So first we'll have Dr. Guilcher talk to us. He's a pediatric cellular therapy physician in Calgary and a medical lead for pediatric cellular therapy. He directs the Childhood Cancer and Blood Disorder Research Program at the Alberta Children's Hospital Research Institute. He has held international leadership roles in transplant consortia, focused on curative therapies for sickle cell disease. After that, we'll have Dr. Jamani speak. He's a clinical associate professor at the University of Calgary, an attending physician with Alberta Blood and Marrow Transplant Program. His practice focuses on myeloid neoplasms, acute leukemias, and allogeneic stem cell transplantation. His research interests include post-transplant late effects and quality of life. Then we have Osisari, who's a registered nurse, public speaker, and sickle cell advocate, whose lived experience fuels her work. As a founder of the Sickle Cell Warriors Collective and a patient advisor in Calgary, she supports global warrior communities. A 2021 bone marrow transplant cured her sickle cell disease, inspiring her ongoing education and advocacy efforts. And then finally, we have Fuma presenting to us. She is a social entrepreneur and health advocate who founded Not Just You. It's a national nonprofit supporting people affected by sickle cell disease. Cured through a bone marrow transplant at age 18, she uses her lived experience to drive awareness, patient support, and policy change, blending science, advocacy, and community leadership. Without further ado, I'll have Dr. Guilcher present, and thank you all for attending. Keep yourselves muted, questions at the end, and feel free to put comments in the chat. And finally, before I forget, this webinar was supported through sponsorship by Sun Pharma.
Great. Good morning, everyone. Thank you to Kareem for the invitation to present and for all of you for joining this morning. I'll be presenting on transplantation for sickle cell disease from the perspective of a pediatric transplanter. I won't be presenting on gene therapy. There's just not enough time today. So I'll be discussing the Alberta Children's Hospital program and giving you a sense of what's happening in pediatrics across the country. So my goals are to discuss a consultation for transplant from the perspective of a transplant physician. We'll talk about key components of a consult that are relevant for the transplanter and the workup in advance. Standard indications for pediatric patients with sickle cell disease, and those indications which are considered experimental or reserved for really very select cases. And we'll talk again, as I mentioned, about the Alberta Children's Hospital pediatric experience and what's happening in Canada. My one disclosure is that I'm the principal investigator of a study which receives funding from Genetics Biotherapeutics. So I'll give you two cases which are quite different from the lens of a transplant physician. So the first is a 4-year-old boy with hemoglobin SS genotype. He's been on hydroxyurea as per the Canadian guidelines from a young age and well tolerated. He's only had one vaso-occlusive event, and this event did not require either admission to a hospital or intravenous opioids. And he has a fully matched, HLA-matched sibling donor, but this donor is quite young. Contrast that with a 17-year-old female who also has SS disease but has no siblings. This person's had a stroke, has ongoing moya disease, and is on chronic transfusions. And alloimmunization is making getting safe blood for this person more and more difficult. This person also has chronic pain, and to date has been well chelated. So the approach from a transplant physician's perspective would be quite different for both of these patients in the pediatric world. So things that we usually like to see in advance of determining who is most appropriate for a consultation, and I'll explain why I use those words in a second, but also to inform the consultation. We have a pretty refined process with the 3 referring programs to us. We receive internal referrals from our sickle cell program in Calgary, as well as referrals from Edmonton and Saskatoon. And so the referring physicians can, and it's very helpful that they do perform HLA typing on patients after discussion, because the donor options are very informative as to what may or may not be possible for someone. clearly a matched sibling donor, as most of you would know, is a very different type of transplant than an alternative donor transplant, either a half-matched family member or someone on the registry. The genotype and disease severity are very important. Typically, we transplant patients with SS or S beta 0 disease. There's a growing literature for SC disease that's sort of beyond the scope of discussion today, but the genotype is important, as well as blood groups, which could dictate what conditioning regimen is appropriate or determine which donor might be most appropriate if someone has several donor options. And if we're talking about a mismatched donor, then donor-specific antibodies will inform the discussion as well. And both the age of the recipient and age of the donor, both even in the pediatric realm, do impact risk assessment and may determine which conditioning regimen is the most appropriate. So practically at our center, I'm only speaking for our site, we have predominantly in Alberta, and I think it's safe to say for Saskatchewan as well, predominantly first generation or second generation African Canadians, and most families want to talk about curative and transformative therapies. However, we just don't have the capacity to meet with everyone who wants to have a discussion, unfortunately. So anyone with a matched sibling donor, we will see in consultation. And for those who do not have a matched sibling donor, which speaks to the importance of the HLA typing by the hemoglobinopathy clinics, we'll have a multi-D discussion about the severity of disease and determine if we should go on to a consultation. So we'd love to meet with everyone. It's just really not possible given the hundreds of patients that we have in the two provinces. So key components that I include in all of my consults are that these are elective transplants, and it's not to say that they're not important, but it means we can take some time, often over multiple meetings, to really make sure there's an understanding of what a transplant is. There's, as a starting point, often a lot of discussion about this is not a quick in and out intervention, but a major commitment to a prolonged medical experience. That also, despite sickle cell disease being a non-malignant condition, I do not want to undermine the fact that it is a condition that is associated with significant morbidity and early mortality. So I don't want to sound like I'm saying that it's not important, but we do have time to make sure that we have good discussion. And that while most children and adolescents are cured of sickle cell disease, there is still a risk of death. And that risk varies by regimen and donor type, but that is typically in the 5% or less range, but that's not zero. There is a risk of graft rejection, which varies between 5 and 15%. So that's a very disappointing outcome for someone to go through this and then to be back to having sickle cell disease again. And then we have to really try to help families understand what chronic graft versus host disease is. And while most people do not develop this complication, it is also a very disappointing outcome to exchange one chronic disease for another. So not surprisingly, we talk about the risks inherent to any transplant, but specific to sickle cell disease, there are some additional points to make. There are complications such as PRES, posterior reversible encephalopathy syndrome, which are higher. And a key point of discussion is, what is cure? What are the expectations? While there are emerging data to suggest that it is possible that some end organ damage might be reversed, I definitely wouldn't overstate that possibility. And so it's really important to state that our expectation is that we hope that we won't see ongoing organ damage or organ injury, but we don't expect the damage that's been done to get better. There's more to learn there, but really important to emphasize that. And also very key is that chronic pain syndromes and avascular necrosis typically do not improve. And this is a very important point of discussion. It's very disappointing for patients to be post-transplant and not have had the explanation that this is the expectation for chronic pain or AVN. And also for those people caring for them, whereas someone who's not educated about this might not be understanding as to why someone might have chronic pain after transplant with the expectation that they're quote unquote cured. So I'll break down the rest of the discussion in terms of donor type, because it really informs who is more routinely offered transplant and the risks and potential benefits. So when we talk about matched sibling donors, which unfortunately isn't an option for most people with sickle cell disease, these are the transplants with the best outcomes and the lowest risk of graft versus host disease, which is the complication that is associated with the most significant morbidity and contributes to the risk of death in transplant for this and other conditions. So the graft rejection rates vary between 5 and 15%. So they're lowest with more intensive conditioning and they're higher with less intensive conditioning. Although the risks of graft versus host disease are the lowest with the non-myeloablative or least intensive approaches, and those would be in the 0% range that you can see. So acute and chronic GVHD risks are between 0 and 20 or 0 and 15% for acute and chronic respectively. And typically the older the person is having the transplant, the higher the risk. Now the NIH regimen, and Kareem is going to speak to this, in the adult population has really changed that narrative for adolescents and adults. So that's been an exciting advance. And the best outcomes are when the patient is younger, but what makes this decision-making more complicated is the person with sickle cell disease might have a very mild phenotype at that point in time, and that may make the referring physician or the patient it would be more likely the guardians understandably more reticent to move ahead if it's less clear as to how severe their disease is going to be. And fertility preservation options vary by age, and notably prepubertal males don't have standard of care options in Canada, and this might inform the discussion as well. So the ASH recommendations published a few years ago for children recommend myeloablative conditioning over less intensive approaches. Kareem's going to speak to the adult recommendation, and I'll elaborate on this a bit further. So the ASH guidelines, and these are for matched sibling donors, I'll emphasize, are a suggestion to discuss transplantation for those with a history of neurovascular disease. Now, a survey by the STAR Consortium of sickle cell providers as well as transplant physicians, there was over 90% agreement that someone with neurovascular disease should be offered a transplant. Of course, family doesn't have to undergo transplant, but to offer a transplant if a matched sibling donor is available. And then for those with recurrent vaso-occlusive events or recurrent acute chest syndrome and a matched sibling donor, again, is suggested that transplant be considered. Now, there's a lot of debate as to how many such events would justify this recommendation, but this is what the ASH guidelines state. And that if these indications are met, the transplantation outcomes are better at an earlier age, not only in terms of success, but preventing further sickle cell complications and organ damage. But despite these ASH recommendations, myeloablative conditioning, intensive conditioning with high doses of chemotherapy are less commonly used in North America. You can see this survey of the highest volume centers in North America in the late 2010s showed that even then, most programs were using either reduced intensity conditioning or the least intensive conditioning approaches as opposed to intensive busulfan-based approaches. And that trend was only expected to increase. So there's a discrepancy between what ASH is recommending and what people are doing. And so why is that difference? Well, the ASH guidelines, to be fair, the best outcomes in terms of disease-free survival are with intensive high-dose chemotherapy approaches, the lowest rate of graft failure. And there's the largest experience with a couple decades of knowledge to inform our discussions with families. The reasons why sites are considering less intensive approaches is we hope that fertility preservation might be better, although with reduced intensity approaches that has not been borne out. But we do have a signal with the least intensive approaches that things might be better. And GVH rates are almost non-existent with the non-myeloablative approach that I'm about to describe. Also, the impact on quality of life early post-transplant is not to be dismissed, and that decrease in quality of life before ultimately an improvement, that decreases less with less intensive approaches. So I'll highlight the practice of what I'll call the NIH regimen, which was published in the New England Journal about 16 years ago, which we were early adopters in the pediatric setting. I'll describe some data in a second. This has really become the standard of care for adults, and Kareem will elaborate on that. But increasingly, this is the most commonly used regimen in children in Canada, but not exclusively. So our experience with this regimen, with our first 30 patients, and again, this is sibling donor transplant, is that we had 100% survival. We had no graft versus host disease, and we had only one patient who had low donor myeloid chimerism with some evidence of hemolysis, but no sickling, and a slightly higher hemoglobin S level than that of their donor. But all the others had exact same S levels as their donor and had what we would call, and I'm hoping that, and FOMA and others will speak to what I would think is a successful outcome. And we were able to wean off immune suppression, which wasn't always the case for the adult cohort. And we have had some successful spontaneous pregnancies with only a couple of these patients actually having reached the age at which they would consider family planning. So this is pretty encouraging, but we needed to validate these results. So we designed a multi-center international clinical trial to validate these results in an international setting. And unfortunately, the first phase of this study, the outcomes were not quite as good. Now, the way we gave one of the drugs called alemtuzumab was different. We gave it intravenously on the study instead of subcutaneously. And you can see that while all patients survived and patients had really good quality of life, even early post-transplant, we had a higher rate of graft rejection than we wanted to see. Now, this is comparable to the adult data with this regimen, but it's higher than what we saw in our early experience in Calgary. And 25% of patients met the definition of what we call poor engraftment. So we amended the protocol to switch how we gave that medicine that I mentioned and to and another modification. And while the results are they're too premature for me to present here, the signal in the first 40 patients is notably better at this point. So what about alternative donor transplants, which most people would be in the scenario of considering either alternative donor transplant or gene therapy, but I'll focus on transplantation. Really, we recommend ideally these be performed on a clinical trial, but the reality is there aren't always clinical trials available, and the reality is we have people in our clinics who are suffering from very severe phenotypes, so we still have to talk about what options might exist. And fortunately, the results with unrelated donors using a new medicine to prevent graft versus host disease have been very encouraging. However, most African Canadians can't find a fully matched donor on the registry based on genetic diversity. So that's not an option, again, for most people. So we then turn to looking at half-matched donors within families. And while the results are pretty encouraging in adults, and Kareem will describe those outcomes, even recent data at the American Society of Hematology meeting a few days ago suggests we really have suboptimal outcomes in children with high rates of graft rejection. So some centers will offer this when our back's really against a wall with someone who's really doing very poorly with their sickle cell disease and a very honest discussion with the patient and family. But these types of transplants are not offered to everyone because the outcomes are just not good enough yet. And this is consistent with the ASH recommendations, which are based on low quality evidence and a conditional recommendation, but I think the more current data are aligned with this recommendation as well. So what's happening in Canada? Well, there are 6 pediatric cellular therapy programs in Canada. All 6 have performed transplants with matched sibling donors. There's variability as to whether those patients have minimal to no symptoms or need to have some degree of symptomatology before they're offered transplant. Our program, based on the success of the regimen and the low toxicity, is willing to offer transplant to those with a sibling donor without symptoms, but that's not the case everywhere. And that's not the case everywhere internationally as well, to be fair. And alternative donor transplants are offered very selectively. So we've done a very small number in Calgary in very difficult situations, and there are a few programs that do the same. There are some that will not offer these transplants at all because, as I mentioned, the outcomes are not as good as we'd hope. And then just one last plug for, given this a CanHeme webinar, that post-transplant survivorship care really must be shared with hematology programs and transplant physicians. We need to follow up on organ function, which may have been compromised to varying degrees pre-transplant. We know that, as I mentioned before, some issues may not get better and in fact may worsen, such as AVN or chronic pain. And there are some patients who need, as one example, attention to their iron status post-transplant, as just examples. We've created nationally, in response to the growing number of people with sickle cell disease and the growing number of curative and transformative therapeutic options, working committee within Cell Therapy Transplant Canada. And we're very proud that we've partnered officially in our terms of reference with CanHeme, and we've got several work products already from that partnership. I don't have time to go through this Canadian algorithm for who we think should be considered for curative and transformative therapies. This includes gene therapy, but these can be referenced publicly on our website. And we have more work that we're planning to do together. So this is a really great partnership. So with that, I'll pass it over to Kareem. This is a young woman who was displeased that I had made her hair fall out and affected her skin with transplant. So she responded by starting her own beauty company, and she's now a neurosciences student at Michigan State University. So thanks, and I'll pass it to you, Kareem.
Okay, great. Thanks so much, Greg, and thanks to CanHeme for the invitation to speak. So I'm going to present an adult update and build a little bit on what some of Greg introduced. Hopefully my slides are moving for you. So here are my disclosures. And as Greg mentioned, the non-myeloablative approach has really become the standard for adults who have matched siblings. And I just want to illustrate, I think, the huge potential of this protocol for adults that, otherwise wouldn't be very good candidates for transplant by introducing this patient, actually the most recent patient we've transplanted with a matched sib donor here in Calgary on the adult side. So this is a 48-year-old with S beta thal, currently on hydroxyurea red cell exchange every 4 weeks. Despite this, 2 to 6 emerge visits, hospital admissions per year. In this year, nearly daily visits to the outpatient treatment area for IV fluids and IV morphine. This patient does clearly have a component of chronic pain, possibly related to their AVN at the right hip. They had an acute chest syndrome in 2024. They have an underlying history of hypertension, depression. They also have sickle cell related retinopathy. So this patient was referred to us in September of 2023. So I just want to highlight the timeline. We had some challenges obtaining samples from siblings who were overseas. We identified a matched sibling donor several months later in January of 2024. We were backed up on consults and was able to see her in July of 2024, and she was very eager to proceed. As Greg mentioned, it's important for us to counsel the patient that chronic pain doesn't improve with transplant. The donor is willing but needs a visa for travel to Canada. We engaged social work. The patient engaged an immigration consultant. And in March of 2025, a donor visa application was denied. Some appeals were initiated. And in August of 2025, donor visa was approved. And we finally had a day zero for transplant in October of 2025, over 2 years after initial referral. This patient did really well in the peri-engraftment period. They did have a flare of chronic pain before engraftment, and we did have to involve the pain service, but this was managed and somewhat expected given our experience. And as a malignant transplanter, I'd say that primarily, I'd say there isn't much we do on the adult side that gives you results that you can visualize like this. So the hemoglobin is on the right, and the hemoglobin S is on the left here. So on the left, you can see there's the ups and downs related to red cell exchange leading into transplant. But on the right here, as the hemoglobin S is going down, that's just engraftment of donor red cells, as is the increment in hemoglobin that's happening recently on the right. So this is really gratifying. But the other endpoints are more important. So besides engraftment of donor cells, this patient was treated for oral and genital HSV about 20 days post-transplant, which resolved. And their opiate use is already down 50% from pre-transplant with no need for IV opiates. So this is a patient that was coming into the day treatment area almost every single day for IV morphine and IV fluids, who is now coming in twice a week for blood work and IV fluids, but no opiates, and is using half of their oral opiates. So this is a really great outcome. It's only day 50 and hopeful that we're going to see further improvement. So as Greg mentioned, the NIH protocol really kind of changed how we approach transplant for sickle cell disease in adults. I mean, it really actually allowed adult centers to take on transplant for sickle cell disease, um, which was previously fraught with a lot of trouble with non-relapse mortality and other toxicity. So it's a fairly simple protocol. There's CAMPATH for 5 days, about a mg per kg total. We're accessing this via compassionate access, and this hasn't been an issue to date. There's a single fraction of 3-grade TBI, and the patient starts sirolimus and receives a peripheral blood stem cell graft. The sirolimus is continued for at least a year after transplant and tapered once the donor T cell chimerism hits 50%. In the adult world, we're usually needing on average about 2 years of sirolimus, which is fairly similar to what the NIH reported. The NIH has recently published their experience with 91 patients treated with the original protocol and a variation on the original protocol. And they're showing great outcomes with 90% overall survival. With the original protocol, follow-up is now approaching a full decade, median follow-up approaching a full decade. So there's a lot of experience, a lot of long-term follow-up, disease-free survival about 80%. Engraftment tends to happen around 21 days for neutrophils and platelets. About a third of patients do not need a platelet transfusion, despite us using a higher platelet transfusion threshold of 50. There is about a 10% rate of graft failure, and no chronic graft versus host disease has been seen. This is even more gratifying. This is from the original NIH paper, hospitalization rate. You can see in the years after transplant on the left here is going down towards 0, and then narcotic use also heading down very quickly in the weeks after transplant. Our experience in Alberta with the match sub protocol has been quite good. We've transplanted now 12 patients, aged 24 to 48. We have patients who are between a month and 8 years post-transplant. Our volumes have accelerated, so we did 4 transplants between 2017 and 2021. We then did 3 in 2024, and we've done 5 this year. All have engrafted without recurrent manifestations of sickle cell disease. We have not seen any significant graft versus host disease, at least none that has required any sort of immunosuppression beyond the prophylaxis with sirolimus. We don't have a lot of follow-up for fertility outcomes, but we know that about 2/3 of our patients who have a year of follow-up resumed menses, and there's been 1 pregnancy. We don't really have great outcomes for the men right now, but there are other centers, particularly in Saudi Arabia, that have reported reasonable outcomes with many patients recovering fertility and having children in the years after transplant. One issue we've noticed that needs to be monitored is proteinuria. The sirolimus does tend to make pre-existing proteinuria worse, and so it does need to be monitored and managed medically after transplant. But only 10 to 20% of patients have an HLA matched sibling donor, as you know. And so we've had a lot of new data coming in the last couple of years, which does appear encouraging for adults with PTCy platforms for haplotransplant. And this is basically the platform that is fairly universal for PTCy. The original paper came from the Hopkins, where they used a reduced intensity fludarabine cyclophosphamide, single fraction of 4-grade TBI, some very early ATG, and then PTCy, MMF, and sirolimus. And then the more recent studies, the BMT CTN 1507 and the Vanderbilt-led multi-center study, both published in the last year, had a slight variation, which they think improves engraftment with the addition of Thiotepa on 1 day and the reduction in TBI to 2-gray from 4-gray. And generally summarizing the results with about 100 published adults, neutrophil and platelet engraftment are slower than the matched sibling protocol. You're going to be waiting and transfusing for more time. Viral infections, things like CMV, Epstein-Barr virus, BK, cystitis are relatively common, as are bacteremias. Graft failure is less common in adults. As Greg mentioned, this is a challenge in pediatrics, but less so in adults. You will see graft versus host disease with this protocol. There's about 5% of patients who will develop significant acute graft versus host disease, about 10% who will develop chronic graft versus host disease. The treatment-related risk of death is about 10%. And one major difference from the matched sibling protocols is you're going to have donor chimerism 100% very early on, usually at the first time point at 2 or 3 months post-transplant. So this means patients are going to be on immunosuppression for a shorter period of time post-transplant, with most patients coming off their sirolimus at a year. What we're learning here is that it's challenging to select the right patient for a haplotransplant. And just to give you a couple of examples of patients we've transplanted with haplo protocols in Calgary, this is a 22-year-old we transplanted who was having about 5 admissions per year for pain crises on hydroxyurea red cell exchange, with some issues with adherence that we delayed transplant to sort out. The patient had a high output cardiomyopathy, bilateral hip avascular necrosis, and was actually attending school in person in between their admissions to hospital for pain crisis, so was functioning fairly well despite these morbidities. We eventually did a haplo bone marrow transplant from dad, and other than a line-associated clot, which is another issue we have seen with our sickle cell patients, the patient developed mild oral chronic graft versus host disease, which did not really need much in the way of treatment and has resolved. And the patient's now 2.5 years post-transplant, in school full-time, has not been back in the hospital or in the emergency room since transplant, so doing remarkably well, and now coming to see us just about every 6 months. But on the other hand, we transplanted a 28-year-old with a hemoglobin S beta thal who was quite sick with their sickle cell disease, 2 to 3 admissions per year on red cell exchange, intolerant of hydroxyurea, and then about a year before transplant, an acute chest syndrome, multi-organ failure requiring a prolonged ICU stay and actually ECMO. And this patient somehow, after a 6-month hospitalization, survived, fully recovered their organ function, returned to work full time, but was relatively sedentary. The patient was HLA sensitized, had red cell antibodies, but presented with reasonable functioning, good organ function, would have met criteria for either gene therapy or haplotransplant based on published clinical trials, and really did poorly with transplant. Had major mucosal toxicity early after transplant, and died prior to engraftment of neutrophils. Did not have the reserve, unfortunately, to tolerate a bacteremia, developed septic shock, and passed away on day 18. So I think we're still learning who the best patients are to transplant. I think there is, a sense that sometimes patients are perhaps too sick with their sickle cell disease. At the same time, we want to transplant the sicker patients who don't have a matched sibling donor, because those are patients who are going to have a poor outcome without a transplant. But where to draw the line, I think, is pretty challenging. I think our outcome with haplotransplant in the adult world kind of reflects the fact that we've reserved this for sicker patients. We've done 7 now, ages 21 to 41. We've had a secondary graft failure after needing to back off on immunosuppression for an EBV PTLD. We've had 2 treatment-related deaths, both in patients who were very sick with their sickle cell disease, who had had ICU stays related to complications of sickle cell disease in the years before transplant. And then we've had 4 really excellent outcomes, patients who were engrafted without graft versus host disease and without sickle cell disease manifestations. We know that we will see early GI toxicity, we will see bacteremia, we will certainly see viremias, things like Epstein-Barr, CMV, BK cystitis, we've seen an HHV6 encephalitis, so we have to be very prepared to counsel patients and then manage them through the significant early toxicity that we do see in adults. Just to talk about some of the challenges I've alluded to, but I, of course, will leave this for our amazing patients, Foma and Osase, who are going to chat a bit more about this. But what we've noticed, certainly in the adult world, is it takes time to get from a consult to a transplant. I think it's hard for patients to make decisions. There is, I think, improving peer groups for sickle cell disease, but it's certainly not the same as our malignant patients who have a host of resources and peers to reach out to. There is a lack of specific education materials. We are really trying to get away from giving out our pre-transplant educational material for patients undergoing transplant for leukemia, because a lot of it really doesn't apply to sickle cell patients. Prior bad healthcare experiences, so we need to build trust with patients. Donor immigration issues, as I mentioned, financial childcare challenges, caregiver support. I have never seen so many rejected applications for disability or social support programs. These are issues that I have never seen with a malignant patient. I've never had a disability rejected for a patient with leukemia, but I'd say I've got a rejection rate of almost 2/3 for patients with sickle cell disease. Fertility, obviously, HLA sensitization is a big problem. It will, require more transfusions, HLA match platelets, and you can have issues with donor-specific antibodies in the haplo setting. And then red cell antibodies obviously can be difficult, and we've sometimes had to amass red cell units for patients through CBS over the span of 6 months pre-transplant if they had difficult transfusion requirements. So with that, I'll pass it on to our patients, and thank you again for having me.
Thank you, Kareem. Oh, so sorry. I think if you can get your slides up, let us know if you're having any difficulties with your computer.
Yes. I had to switch to my phone because my
Sure.
computer, I was having difficulties with my computer, so I'm just trying to share my slides right now using my phone. Okay. Do you see my screen?
Mhm.
Okay, perfect. Hello, everybody, and thank you so much for the opportunity to share my journey and experience living with sickle cell disease and then now being sickle cell free. So my name is Osase Odiase Oluwalanami, and I am a wife. I am a sickle cell advocate, public speaker. I am also a registered nurse by profession and the founder of an organization called Sickle Cell Warriors Collective, which unifies warrior voices through storytelling. So why I decided to have the bone marrow transplant is because I personally grew up with sickle cell disease for 24 years of my life, and I lived in Nigeria for 13 years of my life and was diagnosed when I was 2 years old. So I remember getting sick all the time, and moving to Canada was the hardest and due to the cold and just the changes in living in a completely different country than where you're from. And so fast forward to 2020, um, June 2020 to be exact, I was now working as a licensed practical nurse in Lacombe, Alberta. And prior to this, I was on hydroxyurea, and I wasn't really consistent with the hydroxyurea. Um, Due to like the size of the pill and due to the side effects. And I just, technically wanted to live a normal life. So I was in and out of the hospital due to the stresses of school, work. And one day, June 2020, I went to the gym and I came back with extreme pain in my legs, and that turned into an acute chest syndrome. I was unconscious for 3 days. I was in Lacombe and woke up in Calgary. And after that, I decided I didn't want sickle cell disease to limit the things I could do and limit where I could go. And it was the unpredictability that really sold me on getting the bone marrow transplant. So this was in 2020. And prior to being referred for the bone marrow transplant in 2020, I was actually, sorry, can everyone hear me? Okay.
We can hear you, just your slide is only showing small.
It's quite small. Oh,
Yeah, so maybe I don't know if the phone gets turned sideways, how it would work.
sideways? Okay. What does it look like now?
Yeah, I'm not exactly sure.
Okay. What does it look like now?
Oh,
There
that's
you go.
better. Yeah.
Much better?
Much
Okay.
better.
Okay, perfect. Sorry, guys. So in the bone marrow transplant, the idea of it was actually presented to me in 2016. And I was, quote unquote, in my mind, I was quite young. And I said to my mom and the team, I said, no, my sickle cell disease is not that bad, so I will not be going ahead with the bone marrow transplant. So at the time, they did test my siblings, and my brother was a 10 out of 10 match, but I chose not to have the transplant done in 2016. Now, fast forward to June 2020 when I had the acute chest syndrome. I was now more of an adult, and I didn't want sickle cell disease to limit what I wanted to do in life. And for me, education was very key. And going through the nursing program with sickle cell disease at the time was one of the hardest things I ever had to do because I was in and out of the hospital due to the stressor. So once I was referred for the bone marrow transplant, the whole process from 2020 leading to 2021, when I had the bone marrow transplant, was a whole year. And preparing for the transplantation, I was working at the time, so that meant taking time off work. It also meant going through all the medical evaluations. So that's talking to the fertility specialist, having assessments done like cardiac, pulmonary, and just the whole team feeding me with information about the bone marrow transplant. In between this, I also spoke to Reve, which was the first adult in Western Canada to have the bone marrow transplant. And I spoke to her um, about her experience with the bone marrow transplant. And I will say that really helped me a lot in terms of having someone else who's done it before, talk me through it. However, this did not prepare me for the actual transplant itself. Now, fast forward to September 2021, it is now time for the transplant. Prior to the transplant, I chose to freeze my eggs, and that's with fertility preservation. This was not covered. This had to be out of pocket. I did apply for some grants that helped me. I had savings, I asked family members, and I did decide to freeze my eggs. So the timeline from when I had my transplant and when I decided to freeze my eggs was a whole month. I froze my eggs on my birthday, August 20th, and then I had my transplant done September 30th, 2021. So for my process, I did not have a central line, so I had to have that placed in a central line. Prior to undergoing the bone marrow transplant. Then I also got admitted 5 days prior to the transplant. So for me, I didn't have chemotherapy. I had immunosuppressant called alemtuzumab that Dr. Jamani talked about, and I also had radiotherapy. And so having the alemtuzumab consecutively, as well as some pre-medications like Benadryl and medications for nausea and antibiotics as well. So fast forward, I was fine. I was not weak. I had my whole braids on and everything. I was so excited. And come the day of transplant, no, actually, let me speak to radiation. Come the day of radiation, which was usually it's 2 days before the transplantation. I was perfectly fine, and then radiation happens. And that's where the whole symptoms started to kick in. And for me, it started with my taste buds. And I remember calling my mom and I was crying on the phone. I'm like, Mom, I want cranberry juice. And she's like, Is that why you're crying? I'm like, I guess so. I don't know. And so everything just started to change all at once. And it was quite overwhelming, but I just kept on thinking in my head, it's like, trust the process, trust the process. And so I would say radiation is one of the hardest part of the transplant because that's after the radiation is when I experienced a lot of my side effects, um, such as change in my taste buds and so skin sensitivity. My emotions were heightened and my sense of smell was heightened. I don't know if anyone has ever watched anything related to like Vampire Diaries or vampires where their sense of smell was heightened. I felt like a vampire on that day. I remember one of the nights after radiation, I actually had to sleep with deodorant on the back of my hand because I could smell the hospital, and to me it was making me extremely nauseous. So after radiation, I got a chance to see my brother, who was my donor. I got a chance to see my brother, um, have the stem cells taken out through the apheresis machine. I got to take a picture with him, and then I got to relax, and the transplant was September 30th, 2021. Now, it was just like a blood transfusion. I remember saying to them, "Is that it? Is this all? Like, where's the big moment? Where's the grand moment?" Um, and so it's just like a blood transfusion. They monitor you for a whole hour and then they see how your body is doing. So for the first 2 days, I was extremely nauseous, and that was my biggest issue is the nausea. I was extremely nauseous and I couldn't keep food down. Um, everything just smells just extremely weird to me. I remember the team, the Tom Baker Cancer Center, which is now the Arthur Child. They were extremely helpful. They connect you with the palliative care team. Now, a lot of people have a different connotation of what palliative care is, but in my context, the palliative team was there to actually help you decide what medication worked best for the symptom in which you were experiencing. So that really helped. And the nurses there actually did care about my pain. As a sickle cell warrior, I've experienced a lot of racism, a lot of discrimination, and a lot of like healthcare providers just not caring about how I feel, what's going on with me. But this was completely different. Everybody was hands-on. Dr. Chaudhry was the inpatient doctor, and I remember one day I woke up and I was looking at all my stats, and I remember gaining so much weight. And one thing I found out is, for some weird reason, I think the alemtuzumab makes you retain more water. I've talked to other warriors as well, and they also retain more water. But I just remember telling him like, "Oh, something's off. I've gained more weight, and this is just in 24 hours. I think my body is retaining fluids." And immediately he was like, "Okay, we're going to stop this normal saline, and we're going to do Ringer's lactate." And he was on it. He listened to every single detail that I had. And so for me, September 30th, bone marrow transplant, and then I was discharged actually October 14th of 2021. So I didn't stay in the hospital that long. I wasn't weak at all. I wasn't weak at all. And the main thing for me was just the sensitivities. My hair at the time, I didn't know was falling off, and my skin was sensitive. I had lost my taste buds. And so I got home. And when I got home, that's where everything started in terms of the skin discoloration. When my sirolimus dose was changed, I experienced extreme itchiness all over my body. And I remember going to Dr. Jamani and the entire team, and they were very supportive. Every single symptom I experienced, they recommended a solution, and they gave me a prescription for it. When I was experiencing extreme itchiness all over my body, they prescribed Benadryl to help with the itchiness. When the itchiness went away, I stopped taking the Benadryl. When I experienced insomnia, which was one of the effects for me taking sirolimus and the other medications. They prescribed Zopiclone for me to help with my sleep. And also when I started to have like weird rashes all over my body, I also contacted the doctor, and they walked me through it, the discoloration. They said, that's something that you could experience. So the entire team was on board. The entire team was hands-on, and I had never experienced anything like that as a sickle cell warrior. People actually caring and listening to what you're saying with intention was brand new for me. So I would say for the transplant, it was sort of like getting into the new reality of things. I didn't know what life was like without pain. And so sometimes I would live my life and expect pain to occur. And I think it was when I went swimming for the first time and I was able to be under the rain and didn't experience any pain crisis. I think that's when it dawned on me like, oh my goodness, I'm actually on my way to being, sickle cell free. Because when I came back from my sister's practice, I was under the rain. I was expecting a crisis. I waited, nothing happened. I was in the pool for over 30 minutes, did not experience any pain crisis. And then I said, let me kick it up a notch and actually move to the Northwest Territories, one of the coldest parts of Canada, to continue my education. And let's see what happens. And my entire time there, I was there for 3 years, not one single pain crisis. And that's when it dawned on me that finally I'm sickle cell free. I can actually now live a life that I always wanted to do. I will say life after transplant is a learning journey. Um, it's slow, because your body is healing. I always tell warriors that the healing process was slow in the sense that if you were to cut your finger, you will see the stages of healing happen every single day. That's how slow it was. And I think for me, what worked really well was the exceptional care. Every single symptom, every single thing my body was going through, I would relay it to my care team and they would be on it. They were so responsive to their emails, to the phone calls, because with the transplant, your body is going through so many changes, hence why there's that mental shift that has to occur because you're so used to being in pain and you have a sickle cell regimen that works for you and you've got it down packed. But now you're a bone marrow transplant patient and your life is different. Now you have to figure out, oh my gosh, how do I live in this new normal? So every change that was happening that occurred in my body and that I didn't understand, I related to my healthcare team and they were on it. They would answer every single question I had, and also a strong support network. So networks like Not Just You, by FOMA, who you're going to hear from very soon. I also built a whole community with Sickle Cell Warriors Collective. And so speaking to warriors every single day in different parts of the country and them asking me about my experience, it made me able to like reflect, and also speaking to other warriors who had the bone marrow transplant, and I was like, I experienced like really like discoloration. Did you experience that too? Yes. Dryness? Yes. What did you do? How did you, that connection really, really helps you through it. Because it makes you know, like, one, you're not crazy for experiencing all these things, and two, some of it is actually temporary. So you just have to hang in there. Um, what needs to be better? So in speaking to other warriors, because I really wanted to get a sense of where, everyone's head was at and what their different experiences was. The number one is talking about fertility. So when you have the initial consultation, it'll be really beneficial to have every single member from the interdisciplinary team there. So I'm talking about the fertility specialist, maybe the palliative team. The reason I say this, or even like a patient representative as well, the reason I say this is because one of the warriors I spoke to who just got the bone marrow transplant done in Calgary, she mentioned how because information are mainly tailored to patients with cancer, when she went to the fertility specialist, the fertility specialist fed her with all this information that was only pertaining to cancer patients and did not actually know that she was a warrior and what that really would look like in terms of her treatment. And so all the things she was saying about, oh yes, your ovaries, you're going to go into early menopause, your ovaries might not work, just all these things she was saying to her actually got her extremely scared. And she said to me that if she didn't talk to me, she would not have gone through with the bone marrow transplant because of the fear that was instilled in her due to the speaking with the fertility specialist. So if during the initial consultation, the fertility specialist is there, including, a patient who's also gone through the transplant as well, that way it's informed information. They're receiving everything they need in order to make an informed consent on as to if they want to go through it or not. Another thing that both doctors have spoke about is the chronic pain aspect. Funny enough, I did not know that chronic pain was something that you could still experience. I luckily did not have any form of chronic pain prior to undergoing a bone marrow transplant. But speaking to other warriors, they were shocked that they would still experience a level of pain, and thought that, they would be completely cured and should not experience pain. But maybe deep diving into that explanation of why, the fact that chronic pain doesn't necessarily go away, the pain you have with avascular necrosis as well, and just more explanation on that would really help as well. And also, like Dr. Jamani had mentioned, is tailoring the information specific to sickle cell warriors in terms of one, our radiation dose is not as high as the dose as of a cancer patient, little things like that. So that way we're well informed and we know how to plan. And I would also say just a form of connection with the community support group that really helps warriors through the whole process of it. Because it's one thing to have, theoretical information, it's another thing to have lived experience. Combining both of those things, I think, is really beneficial to the journey of the transplant. And with that being said, I would like to say that those who decide to go um, through the process of having a bone marrow transplant I will say from my experience, it is worth it. I encourage people to do it if they're able to, because it has drastically changed my life. I'm able to travel, I'm able to live in cold environments, I'm able to pursue further education without any pain crisis. And it is a journey. I'm currently 4 years and a couple of months post-transplant, and every day it's a learning curve for me. I'm no longer on any medications, and I do have my frequent hospital checks, but it's a journey that is worth taking, and it's a journey that requires support and guidance. And I think I would not look back. I don't want to look back, and I'm so happy for the life I get to live now.
Incredible. Thank you.
Thank you.
You're so much appreciated for sharing your story. We'll get Foma to upload her slides now.
Awesome. Thank you guys so much. Just a time check. I know we're a little bit over.
Yeah.
I want to check if I still have a little bit of time
Yes,
or
yes, you do. We've booked this webinar for an hour and a half. We anticipated lots of discussion at the end, but go ahead and please do present. We're really keen to hear your story, and then we'll still have hopefully a little bit of time for questions. Certainly, please feel free to put your comments in the chat as we go through, you guys, in case we don't have lots of time at the end.
Awesome. Thank you guys so much. And once again, thank you to the entire team, Raw from Canheem, for having me. This has been such a pleasant discussion to listen to. It's really awesome. Dr. Guilcher was my doctor. It's also nice to meet you, Dr. Jamani. I've heard lots of stories about you from other patients I connect with. So I really, really enjoyed the presentations. As someone who really, really wanted to be a doctor for a really, really long time, this scratched all the right places for me. So thank you guys so much for such an excellent presentation thus far. And Osase, thank you so much for sharing your story. I relate very, very heavily to what Osase said. And I don't want to echo, because of time, I don't want to echo too many things, but I very much related to many of the things she said as it relates to her transplant experience. So my name's Yifoma Muen. As they sort of mentioned previously, I'm a social entrepreneur, nonprofit founder, an advocate, and also I do like consulting work. And a lot of it really has to do with my work in health advocacy, and sickle cell advocacy. And so just to kind of get into my life pre-transplant, here I am, like little Foma. She's so cute. This is probably around the time I got diagnosed, around like age 2 with sickle cell disease. And yeah, my life was like pretty hectic living with sickle cell disease. As I'm sure many of the doctors can kind of understand. Living with sickle cell, your life is just like on red alert. You just never know when things are gonna like when you're going to get a crisis and you have to put your entire life on pause. And so, yeah, it was definitely a difficult childhood. But I think what I'm really grateful for is my mom This is a picture of my mom and I. I'm probably like 10, around 10 or something like that here. And she really taught me how to advocate for myself. She's also a registered nurse. She's been a registered nurse now for probably like 25 years, and has worked on various units. So she really taught me how to advocate for myself and navigate just like discussions with health practitioners. So I'm really, really grateful for that, because I think it really helped set me up. And so yeah, living with sickle cell, like I think I really felt as both of the doctors were kind of sharing the various patient kind of stories. I think I definitely fell into the patient category where I was having multiple pain episodes that would lead to admission. So I was probably at my worst, I was about like 5 hospital admissions a year. When I was on hydroxyurea, I started taking hydroxyurea when I was around, I think like age 10. Or probably a little bit older, maybe like closer to 12. Um, then things got a little bit better, reduced my hospital admissions to about 3. But those were just hospital admissions and not the crises that we would manage at home. So it's at that point, you're looking at like a crisis once a month. And so I was an eligible candidate for stem cell transplant. But what was interesting about mine is I actually went through pediatrics, but I was an adult by the time I had my transplant. So I had turned 18 in August, and my transplant was in September of 2016. And so one of the things that's really unique about my story is that I'm based in Edmonton, Alberta, and obviously Dr. Guilcher's team is down in Calgary. So the team in Edmonton, my caregiver team, they were really, really awesome. And they basically advocated for me to be able to have the transplant because at the time in 2016, they hadn't actually started doing transplants for adults. And so my team really advocated to make sure that before I transitioned to the adult unit, I'd be able to have transplant. And so yeah, they went, spoke to the board, and lucky for me, I was able to have my transplant. And that's how I crossed paths with Dr. Guilcher. So yeah, I was like the oldest one in the clinic, and even when I go for my follow-ups, which I'll talk about, I am the oldest one on the pediatric unit, but it was great because Peds is awesome. Dr. Gilcher, sorry, Dr. Jamani, but Dr. Gilcher's team, they're the best. They really, really are. And as I continue to do my advocacy work, I've seen where they're really giving world-class support. I'm really, really grateful. And I can speak to that in a little bit. But some of my takeaways from like my time with pre-transplant was that I had a really strong caregiver team, both like my team down at the Stollery, Dr. Bolster and Dr. Bruce, they're really, really great advocates down in Edmonton for their patients. And then I personally, because of like my mom being a nurse, I think it really set me up to be like I was a strong advocate for myself, and I was able to scrutinize things. And I think many patients don't have that skill, and like organizations, and there should be wraparound support to help make up for that. But I think that has always kind of helped me. And like I said, I think the pediatric team laid an excellent foundation for me as well. I quite literally slid into, just, was able to get my transplant. And I couldn't tell you off the top of my head. I don't actually know exactly what kind of, I like that Dr. Giovanni spoke about, not necessarily knowing just yet, like, who is the perfect candidate for a stem cell transplant. I definitely think that is my team. I don't actually know, like when I speak to different patients, sometimes I'm like, like I know that there are people who have like their sickle cell was a lot worse than mine, if you might say. But definitely my quality of life is way better now. And I was 18 at the time when I had transplant, and I just turned 27. So it's been a long time now. And I can't imagine what my life would have looked like if I just kept living with sickle cell up until this point. For all I know, I could have passed away due to sickle cell related complications, which is still happening quite frequently, just here in Edmonton that I know of. So yeah, and I think something that I really want to, and this is where Dr. Guilcher kind of comes in when I was recommended for transplant. I think his team, so in Edmonton, they give you like a very, like when you're first speaking to your hematologist, and then a kind of like the cancer team here. Specifically, it's more of the oncology team that leads the discussion and they tell you about transplant. I think the team, not all teams are very versed in how it works for sickle cell. So definitely the first conversations were very, very abrasive. And similarly to Sase, when I had those conversations, I was like, yeah, absolutely not. I'm not interested in having this transplant. It just seemed quite scary when they lay everything out. And I do appreciate that they do that because I think the more transparent care teams are with patients regarding what the process is like, they can make a very sober decision. And then I think when I finally got to connect to the Calgary team, as you know, my family and I kind of had many discussions on whether this is the right decision for us. I think Dr. Guilcher's team does an excellent job at kind of making, like, creating a safe atmosphere for you to make that decision and breaking it down in the terms that you can understand. I think the knowledge gap between like physicians and patient is a big thing for when people want to make that decision. Because, yeah, sometimes just because there's that gap in kind of like knowledge translation, I feel like that leaves information that falls through the cracks. And then families down the line are like, I didn't know that. But like you probably did. It's just, it wasn't clearly explained to you, or you didn't understand what some of the words they said meant. So I find that that's something I see in my work now. As it relates to my transplant, here I am. I like sort of vlogged my journey through transplant. My videos are on YouTube. I kind of want to take them down, but they have seemed to be a help for people who are looking for information since there really just isn't anything out there. So yeah, this was me, undergoing my transplant. My little sister was my donor. I'm super, super grateful. Here she is. She was 12 years old at the time. She was also a 100% HLA match. So super grateful for that she was able to do that for me and quite literally save my life. This was me giving her a pair of Nike shoes to say thank you when she was again hooked up to the apheresis machine. Nike shoes can't really make up for what she did for me, but I thought it was a start at the time. So again, really, really grateful. This was me getting my irradiation, my TBI day. As Osase said, that day really sucks. I always say it was definitely one of the worst days of my life. It just doesn't feel great. The anxiety is a lot. And after, like, I just needed to lay in the dark because I, till this day, have never experienced what your body kind of goes through post radiation. I don't think that was something that I was prepared for. It just, yeah, it's very different compared to everything you go through with sickle cell disease. And yeah, I also again went through the same regimen, campath for 5 days. And I always say to anyone who asks me how was my transplant experience, I always tell people like if you can go through a sickle cell crisis and like make it out, quite transplant is actually like kind of a walk in the park. Like as it relates to how your body feels, you just feel like a general level of unwell, but like the intensity of a sickle cell crisis is, it's undescribable. It's very gruesome. Yeah, it's not great. So like transplant kind of was a walk in the park. It's just psychologically and like you're feeling things that you've never experienced before. So that unknown, I think, is what makes it relatively difficult. And I think the wraparound around, the experiences where the challenges really come in. So yeah, this is me, I think the day before my transplant or the day I had my transplant, the actual transplantation. And yeah, my life kind of changed for the better after that. Of course, you go through the whole, hair loss and everything. That was quite the experience. And in terms of any sort of side effects and things that I experienced, I definitely went through the mouth sores. I always said if I met Dr. Acubutis, I would love to shake his hand for, helping me out during that time. Dr. Acubutis mouthwash really made things quite easy for me. So yeah. Definitely the mouth sores, my hair loss. I also dealt with because your immune system is so low, any sort of like cuts or things like that just took really, really long to heal. So I think I was dealing with the ingrown hair that like kind of got infected in the pubic area. It was like not great at all, actually. And things like that. I also had CMV. So they had to treat that with, I think it's phoscarnet. And that was like a whole ordeal. But For the most part, my transplant process was really, really smooth. I think I basically did, I think I was in hospital for about a month or a little less than a month. And then I stayed in Calgary for the remaining 2 months of treatment as an outpatient in complete isolation. And one of the things I wanted to kind of touch on is I think Dr. Guilcher's team specifically did a great job at, making sure that as like myself and my caregiver really were careful with the precautions that we were taking. So, remaining in isolation, trying to avoid eating food just to mitigate like infection. But trying to make sure I was eating primarily home cooked meals, no raw fish, no exposure to nothing. Quite literally, my mom and I was like an egg and she was the caretaker, and we were very, very strict. My mom ran a strict program. We documented everything. Like these were just things that I think made it very easy for my mom to be at ease and for us to ask questions, which the care team did an excellent job to do at answering. And I bring this up because I think as I talk to more and more patients and they share how their transplant experiences are, whether they had positive or negative experiences, I don't know if things are different now because, maybe the teams are more comfortable with the treatment. It's less new. But I think I am for being quite running a tight and strict program when you're on transplant because of how serious of this is, the risks associated with it. And when I hear certain stories about like, oh yeah, like I had friends come and visit me, I always look at them like, did you have friends come and visit you? That is high risk. This is a very expensive treatment, and we're really fortunate that it's eligible for reimbursement here. But I just think that I really encourage care teams to do the best job at communicating how serious it is, the risks, and that you don't want anything to go wrong. So you should run a strict program within the family unit. So yeah, post-transplant, my life is awesome. I always like to say, yeah, my life is incredible. I do things like jump off bridges, and go skydiving. One of the days I remember post-transplant, was, so obviously I was in Calgary and like, there's like the Bow River. We were staying, in a kind of like a care home, by the Bow River. So they allowed me to go for walks, but I had to go at like a very specific time of day when the path was clear and it was like just my mom and everyone else had gone to work. And I remember going on that walk and it just felt like for the first time I could breathe again. Like it was in that moment is when I realized like, oh my gosh, like, girl, you've been sick your entire life. It's a very difficult to explain, but in that moment I realized, I think at that point I was like maybe a month and a half, post infusion day. And I really realized like, wow, like I have been very sick my entire life and I didn't really realize. It just felt like I could breathe properly. I mean, I always think back to that day. I feel like all my senses were heightened in that day, and I remember it just being so surreal. And even another thing was like looking at myself in the mirror and like noticing like the whites of my eyes are no longer yellow. That's a very small and niche thing that people with sickle cell, deal with. But still, to this very day, I still look in the mirror and I'm like, oh my goodness, like my eyes are like white. I don't have to deal with that. When I was dehydrated, that's how my mom would be like, yeah, I can tell you haven't been drinking water and a crisis can onset at any point in time. They would use my eyes to measure that, but like that's not a concern now. And like, I'm able to do so much. I graduated from university. The stress of life in high school would send me into a crisis. I can't imagine it would have been like to do my entire degree. I did my degree. I started school right after transplant and I was able to complete that. I could run to catch the bus. Again, small thing you can't, it seems so simple, but with sickle cell, literally sprinting to catch the bus, it felt like you could feel the shards of glass in your chest, your cells sickling. At any moment, you need to be airlifted to the hospital. It would take me like 10 minutes into the bus ride to like regulate, take deep breaths, just so I wouldn't go into like full blown crisis mode for running to catch the bus. And so I don't experience things like that anymore, like post-transplant. I can go to the gym, I can work out, the whole nine. I can travel. I do a
Mhm.
lot of great advocacy work. So yeah, I got to meet Justin Trudeau and explain to him about the work that I'm doing. And again, just being able to like fly from Edmonton to Ottawa, no oxygen tank. Again, these are small milestones that post-transplant I get to experience. And that was just not my life before. I went to Geneva with the Canadian delegation and basically represented the country and my organization for a forum for people of African descent. Again, that international trip, no oxygen, no worrying that in a week I'm going to fall into crises. My life is really, really different now, and I'm able to really do advocacy work. In September, I celebrated 9 years post-transplant. And so, yeah, I can't believe it's been 9 years, and I'm on the other side, and getting to advocate for people, but I'm extraordinarily grateful. And yeah, now I get to do advocacy work. And as I kind of close in discussion, I just want to highlight kind of the stuff that I'm learning through working with different families. And essentially, Not Just You is a sickle cell support organization. And we really are just devoted to creating support systems that provide people with the tools and resources that they need to navigate this disease. I really loved hearing about essentially non-sibling matches. Not Just You has a program that's really cool, and we go around to different cities in across Canada, and we try to get more individuals of African descent to join the stem cell registry, in hopes that maybe one day, someone would be able to get a match off the registry. We know it's a really slim chance, and there are still challenges with what that's like, but it's still an effort. It's been 3 years now that we've done the event, and we have had one person who came to our event, got swabbed, and was an eligible match for someone. Obviously, they don't disclose the details, but it shows that it's an intervention that kind of works. And then we also have amazing programs like Bright, where I love that we spoke about a lot of the resources, tools, even like trying to qualify for disability. It's always for the oncology patients, but specifically patients with sickle cell, they don't get access to any of these resources. So we have a program. We went across to various hospitals across Canada, all 10 provinces, basically providing care packages for patients in hospital and their families. And the feedback from this has been overwhelming and really, really impactful. And it really shows that there's limited support for these families. And specifically with cells, and this is a peer support program that we run. It's open to anybody in Canada. And feel free to tell your teams about what we do. Now we actually offer free psychotherapy for anyone who's in this program. And yeah, we're partnered with a psychotherapist, and they actually specifically are training the therapists that work with us. To kind of, one of the things I struggled with was finding a therapist who dealt with people who have chronic illnesses. And that's something that they're working to provide. So we're really grateful to be able to offer this program to people. But through this peer support program is where I learn a lot about people's thoughts and opinions, and experiences with transplant. And so that's kind of what I wanted to highlight as I close. Some of my main community insights is wraparound support is not optional, it's essential. And I think that's something that has been really, really overlooked. I think it was in Dr. Jamani's presentation, he talked about, those peer support groups connecting with these organizations. And we all know sickle cell is extremely underfunded. And you can imagine if it's underfunded as it relates to the clinical side of things, how much more on the peer support side of things. And so we're constantly getting an influx of people coming in, but we don't have the resources to match and support them. And even as it relates to, like I said, psychotherapy, there was no therapist that I could speak to who was culturally informed and also could speak to like the trauma associated with living with a chronic illness like sickle cell disease for my entire life. So I think it's really important that while wraparound support is important, I think that it's something that needs to be, and I always tell pharmaceutical companies that you need to work with these organizations or work with care teams to help fund, these things. And I think I talked about kind of that knowledge gap. Our organization, nonprofits can help that. We also are really trying to advocate for case management services because we think if there was someone who was specifically focused on sickle cell and had a repertoire of information to give families, it could kind of fill up the gaps that you as physicians quite literally don't have the time or bandwidth to. Many people want to have conversations and don't get the opportunity to. So if we have the right support, if wraparound support services are supported, then we can support you guys on the clinical side. Fertility conversations, I think Osase did a great job at speaking about this, but it really just needs to be clear. Because I went through pediatrics, I didn't actually go through the fertility preservation. I didn't experience menstruation for about a year and a half. It was pretty interesting, kind of a bit of a shock. I feel like it wasn't something I was necessarily set up for. And obviously, I was quite young at the time. It's been almost 10 years. While I'm still not talking about family planning, not really planning on having kids anytime soon, it is something that, like, in the future, I don't really know what that's going to look like for me. And so that was my specific experience. And sometimes I'm like, would I have wanted to preserve my eggs? How would I have gone about that? I kind of am like, I guess we'll never know. But I think for others, it needs to be very, very clear. Yeah, how that goes. And as Osase said, it's a very expensive thing. So some people just can't afford it. As well as caregiver support. I think that's a critical gap that wasn't addressed in this conversation or ever. My mom had to use all her vacation hours, she had to basically go on disability. They wouldn't give her disability. All this money she puts aside and all these benefits that she has, she didn't qualify because I was 18 years old and she was my caregiver. And so that all of that kind of goes out the window. And the transplant too, we had to move, we had to get care. I have two younger siblings, we had to get people to take care of them in Edmonton. We lived in Calgary. Like, where's that money coming from? And also, the caregiver, what do they do with their job when you need 24-hour round the clock support, right? So that is like, I don't know how we can address that, but it is a very big gap that makes people like can reconsider doing transplant. And then the last two are kind of like concerns about the care team and their communication styles. As I mentioned, I think there's a big gap. Some families seem to think that, the care team might be overconfident in sort of their systems. And this is kind of what I was speaking about. Perhaps maybe minimizing precautions or not preparing families for any sort of complications, like how to handle that, what to do, what that might look like. And so I really think it's really, really important that, while we communicate in a safe manner, also letting people, like, I think sometimes the harsh reality is very important for them to see, and let them know, like, if you don't take isolation seriously, this is what could happen. That type of conversation. And then I think, again, some community members feel the team readiness as it relates to how we handle complications is really important to discuss, kind of like perhaps when things are going wrong. I don't know how the patients feel about how the care team lets them know things are going wrong, or when they are concerned, like, hey, are they responding properly? How that concern is being met and what that looks like. Obviously, if a family member is responding poorly to transplant, that is a whole level of trauma that we can't get into at this time. But how you can imagine if they're looking at the team and it's like, I don't think they're responding, but I don't know if my loved one is like dying, or if the transplant is failing. These are some tough conversations I've had to have with families and basically counseling them through, like, I'm sorry that you felt like you weren't supported. So yeah, not to say again, I feel like I came and I'm like womp womp womp. Again, I really, really agree that I can vouch and say that I am someone who benefited from this program. My life is completely changed, but I think these are some of the harder conversations as it relates to transplant and how we support the families who are experiencing this. These are things that we need to discuss. So that's all from me. Thank you guys so much. I know our time is far spent. But if you have any more questions or to go into detail, there's so many things you can connect with me or the organization. You can take me out for lunch. Really, really happy to explain further. But thank you guys so much.
Okay. You guys, if we were in a room, I think you'd both have a standing ovation at this point. I cannot tell you how incredibly powerful your stories are and how vital this information is to us as sickle cell treaters, as transplanters. That the patient perspective is just so novel in terms of just so many ways we can improve our care and improve our communication. So I really thank you a lot for taking this time to talk to us. Are there any questions or comments from the audience? I also want to point out we actually have a good proportion of patients who have joined us today. So I do see a good number of patients from my clinic who have joined us. So welcome to all the patients as well to this CanHEM webinar. Any questions or comments from the audience? I think just many things. Oh, go ahead.
Oh, I'll just jump in. I'm a pediatric social worker at the Montreal Children's Hospital in Quebec, and I did see another comment, but I just wanted to, I guess, repeat that the boxes really cheered up our patients. Like there were a few kids that had just really just been having a hard time, and it was just so nice to give a big bright box that felt like a gift, and they opened it and wore the blanket, and one of the children forgot the water bottle, and we're calling the hospital to make sure it was set aside. So thank you so much, and I hope that myself and Child Life can reach out to you more specifically to see how we can strengthen our ties with your organization, especially for our English-speaking population, for the support groups, etc. So thanks for the work you've done and your inspirational story and being so open about that.
Yeah, so a few questions in the chat. Are there high risks of a transplant in patients older than 41?
You know what I'd say our experience is that it probably doesn't relate so much to age. Like we've had patients in their 40s do really well with even a haplo transplant with more intensive conditioning, and our 48-year-old who just went through a matched SIB transplant. I think it has to do with the specific organs that are involved with the sickle cell disease and how fit the patient is before the transplant, with the caveat that how do you measure fitness in sickle cell disease? It's not the same as cancer patients, so I think we have work to do there, but it's not so, I would not draw an age cutoff.
Awesome. And another question is the transplant program available only in Calgary or in Edmonton as well?
So just in Calgary at this time, both on the peds and adult side for Alberta.
Yeah,
Awesome.
and Kareem, you could speak better than I to the adult situation, but there are really only two adult programs, I guess three adult programs in Canada that are offering transplant, but fortunately, there's increasing interest in expanding access, and that's part of the reason we established that working committee, so there can be mentored support for the care teams who are embarking upon transplant for the first time, because there's a lot of nuance to these types of transplants. There are a lot of differences from leukemia, and our risk tolerance is much different. Not that we are dismissive of risk in someone with cancer, but we really do not want death or serious complications in someone who has a non-malignant condition, albeit a very serious condition. So there are a lot of efforts to help new centers safely start to offer these treatments.